current illness perspective, but the long-term effects of measles, where for 2-3 years it can wipe out your immune system, where your immune system doesn't really recognize anything except for measles, and so it can lead to some secondary bacterial infections. So I am encouraged that we are starting to see an increase in vaccination amongst many of our patients, which is great. So the other thing that we've done is really made an effort to how do we keep people safe when they do come into the doctor's office. Okay, so we go through, Prisma's done a wonderful job helping us come up with a protocol that's been in place for that we've used since COVID, but we tweak it with measles just based on how it's spread through airborne, because the measles virus will live in the air for about 2 hours after someone leaves the room. So, you can imagine a waiting room is not exactly the best place to have a child with measles. So whenever we're concerned about anybody with measles, we do screening to see if they're vaccinated, have they had 1 or 2 vaccines, where are they at. Based off of that and what symptoms they are, we triage things and decide if there's any concern about measles. We will do a telemedicine appointment, and then if we need to swab them, we bring them in at the end of the day or the end of the morning, when we can close rooms down for a couple hours and prevent any exposure, not having them waiting in the waiting room or anything like that. So, from a right now we're having to play defense. We should always be playing defense with the vaccinations, but we're having to rev up our defense. So, I've seen several cases of measles all through telemedicine, and I think that's a wonderful tool that we have to be able to figure things out. And we can do close follow-up with our patients with measles. How are they drinking? Are they having coughing fits? What are their eyes looking like? Is there worry that there's a secondary infection? And the telemedicine program that Prisma's helped develop has been wonderful. And, I think this is a prime time to utilize it as much as possible, so that we're not getting other people sick when they come to the office. Because I do think a lot of people are concerned, hey, I don't want to come to my pediatrician's office and get measles, which I totally understand. I would not want to either. And so we've been working really hard to screen every patient very closely, and it's a full team effort from our front staff is where everything starts, and they've done an amazing job, to our nurses and our physicians, having everybody on the same page, understanding really the severity of this outbreak and how really one little small break in the armor can lead to a lot of spread. And whatever we can do to decrease the spread and decrease the amount of work that our public health officers are having to do from a tracing perspective too, we're making a lot of effort in that regard. So that would be my big points, I would say, there for sure.
Good, thanks. Hey, Dr. Simko, how many patients have you actually actively treated? I know that's probably going to be one of the questions.
Yeah, so I've had 5 cases of measles that I've treated, and they've all been different. They all have looked pretty sick, would be the best way to put it. When you're able to see a kid and the rash is alarming, the fever's alarming. Always when they have high fevers, when children have high fevers, they're always going to look sick and ill. But this is kind of a different level where they just really look exceptionally run down. And so I know those numbers will sadly are going to rise. And most pediatricians have never seen measles. I think that's another thing that we have to be mindful of. And the complications of measles is, none of my partners, I can't speak for sure, but I don't believe any of them had seen measles before this outbreak. I think our office has had, 7 or 8 cases. And so I believe it's 7. So, but we sit right on the edge we sit between Greenville and Spartanburg. And so where Spartanburg has been pretty much the heaviest outbreak of measles, we're sitting on that line. And feel like it's creeping. Yeah, I think the numbers are showing that it's starting to creep for sure.
Yeah. Good deal. Thank you. I'm going to go to Dr. Robin LaCroix, who is a pediatric infectious disease specialist. So she can physician and she can give us some additional information. Give me one sec. There she is. Dr. LaCroix, you're on mute.
Thank you. So thanks, Tammy, for the opportunity. Dr. Simko really laid a tremendous foundation for us in the sense that this virus is extraordinarily contagious. When you look at numbers that began in very small numbers, and now every 4 days, we're looking at hundreds more children infected. Each person that's infected has the potential to infect 12 other people. We worry when we have the disclosure by Department of Public Health of highly populated places like Walmarts and other areas that have had someone in that environment who is actively contagious. I remind people of the Disneyland outbreak a number of years ago, which began with a single person who was in a group of folks, even in an outdoor setting, and infected many, many people at that one exposure at the amusement park. So now we have the potential for the latest cases to have spread this virus among others unknowingly often, because 4 days before you're even sick, you're potentially contagious, which is why it is so difficult just with isolation and quarantine to control this virus. And Dr. Simko made the point that vaccine is the way that the states around the country have controlled and extinguished this as a community transmission problem. And so when we talk with families and we talk with parents and even young adults who may not be vaccinated, now is the time to choose to go and receive your immunization. The immunization is very effective. It's one of the tools that we have when people are exposed. If we can identify that exposure within a short window, 72 hours, basically 3 days, we can give you an immunization and your body will make its own defensive antibodies to protect you from this virus, and you can avoid quarantine. The beyond that window, say that it's later that you're notified that you may have been in exposure, then we have other methods that if you're at high risk that we can help protect you. And we have seen this within the Children's Hospital environment, both in children that have become ill enough to be hospitalized, and yet we know that they may have young siblings, less than 6 months of age, that they have subsequently exposed inadvertently. Again, they didn't know that they were going to transmit measles to their sibling. We're able to intervene and try to protect those children as well from acquiring measles as a disease process. Dr. Simko mentioned that not only is there an acute period of significant illness requiring children to need IV fluids just from their degree of illness, requiring children to be monitored for secondary infection. This virus is and does have a long-lasting impact on that person's ability to respond to infections for months after measles is cleared. So the long-term effect and the risk of secondary bacterial infection, which can cause really severe pneumonia, some even requiring surgery, all of those risks of infection are there. Certainly, encephalitis is described as a true complication of measles, and in numbers reported as high as 1 to 1,000 people that develop measles may go on to develop encephalitis. So again, that's inflammation of the brain, causing children to be disoriented and to really not be able to function in the way that they normally would as a child. So all of these complications of a virus for which we do not have an antiviral, we have to remember that what we have is supportive care. And what that means is us being able to keep them hydrated, to maintain some degree of temperature regulation, to monitor for seizures or other complications, to monitor for secondary bacterial infections. But we cannot give you an antiviral for this particular virus. So I think the idea around protection becomes even more imperative, that you protect both yourself and your children. If you have not had a measles vaccine, getting that done, as these numbers now, we're looking at in a week's period of time, we're approaching 200 plus people actively infected in our community. So the opportunity, if you are not immune, to come in contact with the virus unknowingly on your part is part of the risk that we take when we aren't protected with immunity provided by this vaccine. It means that we are basically without the surround armor that we need from our immune system to fight this virus off before it can make us sick.
Thank you, Dr. LaCroix. And since you mentioned adults, we're going to go to Dr. Helmut Albrecht, who is a infectious disease doctor, and he'll talk about adults and what they should be thinking about. Here we go. Dr. Albrecht.
Yeah, thank you, Tammy. Helmut Albrecht, I'm not spelled like the helmet, which even you did, Tammy. It's Helmut. But adults get measles and actually behave less good than some kids. Actually, we have right now the largest outbreak in the US, and it's going to get worse before it gets better. So adults are affected and infected. And with that, since being in an active outbreak, the recommendations actually change. There's always been, you should either be immune, and I'll tell you how that works, or you should get a booster vaccination if you don't know that you're immune. And immune is that you were born before 1957. Or if you're not at risk for acquiring measles, one dose of vaccine is actually okay. Otherwise, if you're at risk, you should have 2 doses of MMR. And if you don't know that, you should either get another vaccine, or you should check your immunity. High risk groups in this case is more people that get infected, not the ones that do badly, like highly immunocompromised patients. They're going to do well with measles, but you can't vaccinate them, right? It's more about students, healthcare workers, travelers, and people that get into an active outbreak. All of us now are in that because we're in an outbreak. All of the cases are in the upstate, but hundreds of people are already in other parts of the state in quarantine or isolation. And we will see this here. We've had several exposures, large exposures, outside of where the cases are concentrated now. And it will get better because it's such an effective system here, but it will get worse first because you will see cases of measles in the healthcare system here, and you've got to be ready for that. So if you don't know your vaccination status, make sure you may get another vaccine or get your immune status measured, which can be measured pretty easily. All of these things we put in place as a healthcare system that we know how to isolate people, how to quarantine people, how to vaccinate people, and how to diagnose people. Adults run pretty similar to kids. There's the incubation period, 10, 14 days. The real problem is the second phase, the so-called prodromal phase, before you get the rash. 4 days, you're infectious. There's 3 Cs, coryza, which is runny nose, cough. All of that looks like a bad flu. And then there's the third C is conjunctivitis, which is the pink eye, red eye, which makes it differently. Not all of the patients have that, but if you have one with that, you got to really worry that you don't expose other people. And it's infectious 4 days after the rash has started. So, but the four days before, 3 to 5 days before the rash starts is where you spread it a lot. And again, people who don't have immunity, you will infect 90 to 95% of people that you come in contact with. And contact is, as said before, walking through a room that somebody else with measles has been in the last 2 hours, because the virus hovers around. And we have lost herd immunity. I don't like that term, but because we are not cows, but we have lost our ability to contain this with the immunity that we have. So we need to revaccinate people. And the main reason to get vaccinated for a lot of things is for our community, not for yourself. The ones that need it most, the immunity, can't get it. Highly immunocompromised patients, this is a live vaccine, can't get this vaccine. The complications are similar as in children, but they're more common. If you have complicated measles, have brain involved, have pneumonia, have lung involved, have other complications, mortality jumps dramatically to 15%. It's not just a red spot disease that you can make fun of. This kills people pretty regularly, especially if you don't have immunity. The one thing that's not talked about enough is that now that these kids that are not vaccinated aging out and becoming adults, they also get pregnant. Measles is not good in pregnancy. We can't vaccinate you for this when you're pregnant. You have to be vaccinated before. But that's the only way that kids under 1 year can get immunity, through the mother. And the other thing is that 50% of women that get measles in the first trimester will not have a good outcome, whether that's miscarriage, stillbirth, or a child that has significant congenital abnormalities. Plus, the child is not protected, that's growing in the womb and can have significant primary measles, which is not good in the first year of birth. So there's a lot of issues in adults that are tacked on to this outbreak, which is still mostly in kids, but we have 20% of the outbreak happens in adults, and we're very worried about them.
Thank you, Dr. Albrecht. We're going to go to Dr. Elkes, who is an emergency medicine physician, to talk about how we're managing people, the access for people who might be coming into the emergency department. Dr. Elkes.
Yes, ma'am. Thank you. So I'm Dr. Elkes. I'm one of the emergency medicine physicians. I cover several hospitals within the upstate across our region. And then I also work with emergency management with Prisma Health. So I can't speak to some of what our response has been throughout this. And kind of seeing it progress from August, from just a few cases and kind of knocking on our door to where we're currently at, has been both predictable and disheartening to watch unfold. So seeing just have a couple cases have that snowball effect and pick up speed with the severity and the infectivity of measles has been really something to watch over the holidays. I see a lot of questions about how many people are coming through our ER and hospitalized with this. Our pediatric specialists have done a great job kind of touching on how one of the big threats of measles is that it causes that secondary infectious process. And I do want to point out that over the last 7 to 9 days, we've had upwards of over 200 new cases. It's doubled just in the last week. So we really haven't had an opportunity to have those delayed secondary effects for the vast majority of the cases we're seeing. The other 200 have happened over the last 5 or 6 months. So this is kind of one of those things where we feel like we're really kind of staring over the edge, knowing that this is about to get a lot worse. As far as the impacts to the emergency department, one of the biggest things is the degree of how infectious it is. With it being airborne, these patients require specific isolation precautions, and a lot of effort from our staff to be very vigilant. So we're pushing policies and systems in place to ensure that visitors and patients have masks on when they come through the door until they can talk one of our nursing triage staff and we have a chance to speak with you about your risk and your exposures, so that we don't expose others in the lobby. So we don't want someone to come through with a concern for measles. We want the first person to contact them to be a nurse to talk to them if they have any further risks, so that we don't expose others. And then from there, right now we're in the midst of a respiratory viral season. Every winter, we see a massive uptick in emergency departments for volume and utilization. You see it across the country, and we're no different for having spikes in wait times. And it's really all hands on deck to ensure that we keep things safe for the other emergencies that happen every day, your heart attacks, your traumas, your strokes. We want to make sure that we're still able to have capacity to see all those, in addition to the spikes in respiratory illnesses we see. So now with this additional patient load of measles requiring our isolation rooms, it absolutely does put a strain on systems. And so the only exit I see for this getting better is an improvement in the community to getting vaccinated.
Thank you, Dr. Elkes. I'm going to go back to Dr. LaCroix because I think some of the questions in the chat probably are for her. Dr. LaCroix, all right, I'll start with the top. So the first question, some of these may be questions for our state agency, Department of Public Health. And so if you're looking for specific numbers about where the person, what numbers are in the Midlands and what numbers are in the upstate, that really is a Department of Public Health question. I know that they came out with an update today of the latest information. So if you're looking for that, I think you probably need to go directly to the Department of Public Health for the most current information. The one question was about, have we seen hospitalizations from measles? Has PrismaHealth seen hospitalizations from measles at this point? And I don't know if you have that answer or not, Dr. LaCroix.
Department of Health did publish, I believe in last week's communication, the cases. Those are reportable. We are reporting those. And yes, there have been hospitalizations related to measles.
Okay. This is a question about, and I don't know that, and I don't know if the DPH information has whether we've had patients diagnosed with pneumonia or encephalitis. I don't know if we have that information.
So DPH is collating that information and will release, the breakdown of what has required people to be hospitalized. Because also remember that someone could be in the hospital for an entirely different reason, such as having been in a motor vehicle accident, who also could have measles as well. So the way DPH does these investigations and reports this information out requires them spending the time to understand a hospitalization due to measles or a hospitalization of a patient who also had measles, if that makes sense.
Good deal. This is a question about spread. All the cases that we're tracking and, are being tracked by our South Carolina agency. And of course, we've seen the spread already go from the, upstate and Spartanburg down now to the Midlands area through some exposures. But this question is about whether, I guess, maybe how easily it would spread to North Carolina. We don't know of what cases are in North Carolina because that's, not it. We're actually not in North Carolina, but I don't know if you wanted to explain about, spreading like through areas in general.
Right. So if you think about the world being a very small place and that people are very mobile and travel and move between regions, they have family members in that region. They may be there for an athletic event. They may be there for any of a number of different reasons, and subsequently became exposed from one area. They return to their home community, and that's where they become ill, and thus their exposures in their own home community provide another circle or an extension of a circle from what we call the epicenter of the outbreak. So part of the very, very difficult work that DPH is doing is reaching out to each of these families directly and understanding, where have you been? When you look at the DPH reports and they say, if you were at Costco, if you were at X, if you were at Best Buy during these times, you could have been exposed. That is because they've had a conversation with those index cases and asked them all that information that they're able to then piece together. Here were risk of exposure. So that's how the linkages that you see reported from other areas back to the Spartanburg area is that someone has traveled. They also have outlined well for us that there isn't any clear link that they've been able to uncover. And so again, making the tracking of the spread concentrically of an outbreak much more difficult. Over the holidays, there was a lot of travel. That's where the reports came out about exposures in airports and other areas outside of that area. It's really related to the outbreak investigations.
Okay, thank you, Dr. Croy. So this question is about, is there a way to categorize the severity of illness in hospitalized patients? And I don't know if there is or not. That's just what the question says, Dr. LaCroix. And I don't know if Dr. Albrecht or somebody else, I'm not sure about that one.
There's not enough patients hospitalized that this doesn't become a privacy issue, that we would like not to go over that. But it's, I think it's very clear if.
I was going to say, I didn't have you popped up. I just wanted to make sure, start over.
There's not enough patient hospitalized that it doesn't become a privacy issue. If we talk about individual cases, we would like to avoid that. But it's very clear that patients don't get hospitalized if they have red spots, right? So complicated measles is the reason for admission, or your other diseases that you have that usually puts you at risk for severe disease as well. So yes, and you can look up what complication rates are. There are pretty high in this population. Measles, a subset of measles encephalitis can occur up to 50 years later. Just saying, it doesn't occur with measles virus from a vaccine, but it does occur with the measles virus that you get throughout an outbreak such as this. You can develop as an adult brain inflammation. It's a special subset, but that can occur a long time afterwards. But patients that we admit for measles are often critically ill.
Dr. Albrecht, the question is, if someone is exposed to someone with measles but has not experienced symptoms yet, could they get the vaccine? And would it prevent their illness and make it milder?
It would likely not. We do vaccinate in outbreaks such as this. We offer catch-up vaccine, and you may get a milder disease if you get vaccinated throughout the initial period, not when you develop symptoms, obviously, which you become infectious. And we do vaccinate people. It doesn't hurt to vaccinate somebody with measles, but the effect is obviously significantly diminished through this.
And Tammy, the hard part.
LaCroix, don't let me go back to you. Give me 1 sec.
Okay.
Pop you up. Give me. Here we go.
Sorry.
No, you're good. There you go.
Sorry. The difficulty with often identifying someone who is exposed is that by the time they know they've been exposed, we pass the 72-hour window to get the vaccine in. Because remember, they were contagious for the 4 days prior to the development of rash. So the difficulty that Dr. Albrecht is bringing up is that that very early identification of exposure is more difficult to get our arms around. So being proactive, and even now that we are in such a tremendous outbreak situation, the recommendation that babies as young as 6 months of age begin their MMR vaccine series to try to get some protection to them, to make them more resistant to acquiring measles when there's so much circulating in the community.
Dr. LaCroix, the question is, can you speak to how changes in the vaccine policy, or has changes in the vaccine policy at the federal level, do you feel like that's contributing to confusion or hesitancy around vaccines?
So MMR is still a foundational, strongly recommended vaccine. So the maintaining the measles, mumps, and rubella immunity status of a community, we know requires 95% of the people in the community to be immune. And so this was foundationally put into that recommended group of vaccines. So I believe that everyone is unified in believing that the protection provided by this is the most effective way to prevent and control transmission of measles.
Dr. LaCroix, the other day you talked about how it's a standard practice for physicians to talk to their patients about vaccination. So can you address that?
So with every visit, particularly in pediatrics and in our family medicine primary care colleagues, every visit is considered a vaccine visit, because the foundational vaccines, the ones that are in the recommended group, are all there and effective at preventing incredibly serious illness. And so those conversations at the visits, your healthcare provider should be having to talk through, here are the recommended group, here is the reason that we recommend these, here are the diseases and the seriousness of them that these prevent, and listening with the parents to understand their questions and to share how we see those children being protected and the risks that we see them at, whether it's attendance at daycare, attendance at church nursery, wherever they might have exposures, being able to share that observation that the parent may not have seen as necessarily placing their child at risk of acquiring these infections.
All right, I'm going to go back to Dr. Simko because they're asking about some procedures. All right, Dr. Simko, the question is, can you talk about exposure in schools? When do students get sent to the hospital if they start experiencing measles in schools? Students asked to mask. I mean, how has that been working?
So I can't speak exactly as as to the school protocol. But one thing that the flow that we would receive is that a parent would usually be notified, hey, your child's been exposed to measles. You know, you need to contact your pediatrician. Schools have your immune records. They know whether you're immune or not. So if you're unimmunized or under-immunized, so say you've had one of the two vaccines, you would have to go, they would put that child into quarantine for 21 days. So that's 21 days where somebody is sitting at home, and a parent would have to stay with them. I don't think it's not like they could go somewhere else or have somebody else watch them without potential risk for exposure. But so from an economic impact, that can make a huge impact. I would say they would not be recommending to go to the hospital. I would say to contact their people. What we usually get is a phone call from the parent. Hey, the school has told us they've been exposed. They've started having symptoms, and we kind of take it from there. Most times we'll hop on a telemedicine call with them, with the family. We'll walk through things. What kind of symptoms are you having? How long have they been? Do you know when the exposure was? If the school has told them. And we kind of go from there. As far as I know, there hasn't been masking in schools. And I don't know if anybody else can speak on that, but and the effectiveness of with measles. So because it is so highly contagious, and really from a prevention standpoint in the room, you really have to be in what we call like negative pressure room, so that that virus is not just recirculating into the air.
Dr. Simko, they're asking if patients are being cooperative. And we talked about this earlier. Have patients been cooperative with protocols that offices have put in place to prevent spread? Are they accepting masking and those kinds of things?
My experience has been they've done a phenomenal job. I think one of the things that we do here is we'll ask people, hey, if you're not unimmunized, before we bring you in the office, we just have them stay in their car. We're lucky we have a freestanding building, so we have them sit in their car. We call them when we're ready. We walk them straight to the back to their room. We're doing everything we can to avoid any exposure. And I've had no pushback. Parents are really overall pretty appreciative, I would say. The way I present it is like, we're just being neurotic, and the families are usually like, we like you being neurotic. So it's something that we take a lot of pride in screening people, asking people, trying to communicate. And very rarely do you have pushback. I haven't really experienced it. People are really more appreciative because they do know it's in the area. It is something they're very concerned about. It's something, I got asked the other day, are we overemphasizing measles, or are we, what are we, is it being sensationalized? And I said, absolutely not. This is a really serious condition with a lot of different repercussions, both acutely but chronically, and exposure to other people. So, I haven't had any pushback really whatsoever. It's been more appreciation and understanding for what we're doing right now, especially in the upstate.
Thank you, Doctor. I'm going to go to Dr. Albrecht. Dr. Albrecht, I think you were
asking. If I speak on that as well?
Yeah. Oh, yeah. Hold on. Let me go back to you. I'll come back to you, Dr. Albrecht. Give me one sec. All right, Dr. Elkes, go for it.
I wanted to add a little bit to add on patients, particularly around the protocols. And first off, I want to thank Dr. Simko, LaCroix, and a lot of our pediatric ambulatory offices. It's no small amount of effort that they're able to see these pediatric patients and these measles cases in their office. And I know people have anxiety around that. And really the way to do it safely is with preparation and with effort. So when these patients call in to schedule appointments, they've gone to great lengths to make sure that they can do that safely and get them directly into a room that's both safe for that patient and for others without exposing anyone. So what they've put together is very impressive and appreciated. In general, what Dr. Simcoe's described about patients being appreciative when you talk about your masking procedures and your isolation precautions. In general, they do understand it. In the emergency departments, I do occasionally encounter people that are resistant to these requests for masking, and to that, admittedly, is a little bit of a struggle for me. Because when I ask someone to mask, it's not even necessarily for themselves. It's for the protection of the community and those around them. So when I ask someone who's at risk for measles or concerned for measles, I want them to get into the isolation and adhere to these protocols for the safety of my staff and for the safety of those around them that might be immune compromised, and this would be a devastating illness for them to contract. So honestly, for the same reasons that I encourage people to get the vaccine, I encourage people to adhere to these policies to make sure that we can continue to safely treat others.
And Elkes, there's also a question about how much additional work is happening because of this outbreak, in addition to the other things that are happening. Can you talk
Yeah,
about that?
absolutely. So there's a huge amount of additional work happening. A lot of it is back end administrative things to ensure that these policies and procedures are in place to continue normal operations for our patients. So all of our pediatricians, all of our ER physicians, all of our adult doctors, they want to continue caring for their patients in their clinics, in a safe manner. So making sure that we have to dedicate this amount of resources to still see the measles patients and to ensure everyone else's safety is not a small amount of effort. Particularly any of those that get admitted or come to the emergency departments, they require these special negative pressure rooms, which are in limited supply in any building. And taking those offline or waiting for one to become available is a finite resource that we have to manage. It is something that we try and balance with the other daily emergencies that we see. So one of the things I do want to put in a plug for is we did turn on our Prisma hotline to address some of this. It's kind of a one-stop phone number that people are able to call into to either schedule appointments, and we can directly route you to either a telehealth appointment through your provider or to arrange for one of these throughput visits where you can safely stay in your car until a room is available without exposing others. So if you have concerns or questions about measles or are trying to schedule with one of our providers, you can call in to 833-2-PRISMA. That's 833-2-PRISMA or 833-277-4762. And that's a general Prisma hotline that we have set up to kind of collect all of these. It's something that we had turned on during COVID and has now been repurposed for the latest re-emerging and emerging outbreak.
The other part of the question, Dr. Elkes, was, have we been turning away patients or been more judicious about admitting patients? Which I know in the emergency part we really do that. But anyway, and how much additional time is being spent on measles because of what all that's happening?
Yeah, absolutely. So I think I've given a little bit of an outline of how much of my time and many people on this call have spent making sure that we have safe procedures in place. I can tell you that one of the things that I love about my job as an emergency medicine doctor is that we do not turn away people. That is not something that I ever have to do or want to do at any point, and is a big part of the reason why I enjoy being an ER doctor. And I know that many of my colleagues and the pediatric and adult colleagues here, they don't want to turn away anyone in their clinics either. And to my knowledge, they are not because of the efforts that we're putting in place.
Thank you, Dr. Elkes. I'm going to go back to Dr. Albrecht. All right, Dr. Albrecht, so the question, I think you answered it in the chat, but I want you to answer it here. The question was about if your child received 2 MMR vaccines, should they still receive a booster later in life?
You're considered fully immune, and that's lifelong immunity. The protective effect is lasting. It's 97 percentile. So it's a really, really, really effective vaccine. But if you have an event later on in life where you lose your immunity that you got through MMR, like a transplant, like certain cancer chemotherapies, you should restart the vaccination. But those are special circumstances where you would know that.
All right, I think that's all of our questions. I'm going to go back to all of our docs just for their final thoughts. And I'm going to start with Dr. Simko. Dr. Simko, final thoughts?
Okay, so as far as time frame goes, just to touch on that, if I see a patient that we're concerned about measles and we swab, it adds about 45 minutes to for every patient with measles. I call Department of Public Health, let them know. They call me back. We have a conversation. We get all their information. So it adds about 45 minutes or so to each patient, that we're concerned about measles. I would say somewhere 45 minutes to an hour. Just waiting on return phone calls, different, talking through things. Every situation is different. But one thing I would just really ask, from our patients, if you call and you make an appointment and you're concerned about measles or you've been exposed, just please tell the front staff. We can make online appointments with MyChart appointments. Please don't make an in-office appointment without notifying someone. It's a really important way for us to be able to prevent the spread throughout our offices. And we're constantly screening as an office and as providers and nurses and front staff, and we're trying to catch every case. But I think there's always that story of, someone calls, they may know they've been exposed, they may not. Child might have cold symptoms. They're like, I don't think they have measles. I'll just go in. And that can be an absolute nightmare situation from an exposure risk for the number of people that you can potentially expose. So I would just ask to be extra cautious. I mean, we're screening when you call, but I'm just asking people to be extra cautious when they're making those appointments. And that would really help us to stream them out. It'd be wonderful if people are just open and honest about what they're concerned about or the symptoms, so that we can best figure out how to get you seen in a safe manner for you and for others.
Good deal. All right, I'm going to Dr. LaCroix.
Right. Thank you, Tammy. Just to add another piece to the question on the time and the different provisions, throughout our facilities, we are working to reconfigure spaces to be sure that we can safely move folks who have concern that they've been exposed, have concerns that they may have measles, through both our outpatient facilities and our inpatient facilities. And so setting up protocols, setting up treatment guidelines, making things readily available to our clinicians are all of the background work that has been going on for weeks now. And really since the first case was announced, we were all holding our breath. And when the first cases were announced, the first meetings began to allow us to be prepared. And as each week comes, we are adding layers and new complex protocols to the way that we are stepping up to be sure that the community can be cared for.
Thank you, Dr. LaCroix. Dr. Albrecht.
Yeah, I was just sent a direct question. Can you speak to whether those who had been vaccinated in the 1960s should become revaccinated? If you know, am I unmuted? Yes. If you know that you had MMR, you're good. If you don't know what you had, you're not good. So either get the MMR vaccine or get a check for immunity, which is a blood draw, and will tell you the answer in 2 days. Other than that, public health is worried about this. You should be too. This is a different beast than COVID. This is much more infectious. This is potentially deadly. And public health is a team sport, right? So we're happy to play pilots. The passengers, to get this safely on the ground, will have to work with us to do this. But everybody needs to do the right thing. Stay up, stay informed. There's daily almost announcements where another exposure occurred. If you were in this exposure, you need to isolate for 21 days, which means that you should really monitor your symptoms and be very careful that you don't expose others, especially if you should monitor your symptoms. You don't have to stay at home necessarily, but you should stay at home if you start getting any symptoms, even if you don't have a rash, right? The ones we talked about. So again, help us out here and we'll get through this.
Thank you. Dr. Elkes.
I just want to thank everyone's time today. This has been a lot of effort on my part and as well as my colleagues as to making sure they're prepared and safe for this. So seeing this much attention on what we're going through gives me some optimism. And that's something that I really needed. So I needed some optimism for everyone coming on and having attention to the outbreak that we're going through. And I really appreciate what Dr. Albrecht said about this being a team sport. I can make all the preparations in the world to make sure that we can see measles patients here, but the only way out of an outbreak is really to improve our vaccination rate until that 95% mark where we're safe as a community. And that's what I'd like to see. I'd like to see us safe as a community and for preventable diseases to be prevented.